So this is a really informal talk. We've been doing it for a couple of years now. We started before the pandemic in person, and then took a break when the pandemic started, and then transitioned to this online format. It is super informal. We have slides we're going to go through, but you can feel free to put questions in the chat box or unmute yourself if you have things you want to say. If you're not talking, if you can, mute yourself so that we won't be hearing background noises. I know some of you have little kids at home and other things going on. So just if we can be muted, if we're not talking, that makes it flow a little better. We usually take about 2 hours, but again, this is super casual. So if you need to get up and do something, you can certainly be listening in the background. There is no test at the end, so whatever you want to put into this and whatever you can take from it is what we're just hoping to be of some help for you guys. So these are the midwives at Delaware Valley. I'm Jennifer, so I'm one of the midwives, and Miranda is also here with us tonight. She is at the hospital, so she may be popping in and out doing caring for people who are there. Nikki is on the bottom, and then Dawn is on her right for you guys. There are 4 of us at Del Val right now. We are looking and about to add a 5th midwife, which is super exciting for us. If you haven't met us, we'd love to spend some time with you in the office before we're with you during your birth, because we are the ones who do all the vaginal deliveries for the practice. So if you've been with the practice before and had a baby more than a couple of years ago, you might not have had a midwife. We had a different model back then, but we have switched over, and now the midwives are doing all the vaginal deliveries unless there's a need for an operative delivery, so like a vacuum, or a need for a C-section. So knowing that there are 4 of us, hopefully in the time that you have left, you'll get a chance to meet us, so that we'll be familiar to you when you come into the hospital. I know some of you are pretty familiar with us, either from past babies or just having seen us a lot already during your pregnancy. Just a quick kind of understanding for those who don't know what a midwife is. Midwives are highly educated, so we all have at least our master's, if not our doctorate. We do through a lot of training on supporting women throughout the lifespan, but very particularly during their pregnancy and birth. We are kind of considered experts in vaginal birth and trying to optimize vaginal birth. So we really focus on being present for you. We work with a great team of the doctors that we work with. But we found that since we switched to this model where the midwives do the bulk of the vaginal deliveries, we've actually reduced our C-section rate and upped our patient satisfaction rate, because we're just able to be more present with you during your labor at the hospital.
Hi guys, it's Miranda. Glad to be here tonight. Hi. I think that I've gotten to meet a lot of you. If I haven't, please schedule an appointment with me so I can get to see your beautiful face in person, and we'll know who you are when I take care of you when you're in labor. We're going to just do a brief overview to let you know what we'll be talking about tonight. We're going to talk about the 3rd trimester, which is from 28 weeks until the time of delivery. And we'll kind of talk about what to expect in the office setting, what testing you can anticipate. We're also going to talk about labor, when to communicate at home, in the office, and when you come to the hospital, what to anticipate for your birth once you are here, the first hour after you give birth, your postpartum stay, which is after you have your beautiful baby, the first few weeks at home, and then we'll talk a little bit about birth in this time of COVID, because we know you guys always have a lot of questions about that, so we'll cover that pretty thoroughly for you as well. All right, so let's talk about the 3rd trimester. You guys are in the home stretch now and getting closer and closer to meeting your new beautiful baby. So we're going to break down the last trimester. We're going to talk about your prenatal visits, like I said. At 28 weeks, which starts your 3rd trimester, we're going to have you come in more frequently. you've been coming to us every month, and now we want to see you every 2 weeks, or occasionally more frequently if you have high risk factors. But for most of you, it'll be every 2 weeks. Um, you may hear some of your friends having an ultrasound at 32 weeks. You may hear it called a growth ultrasound. This is mostly reserved for women with high risk factors like diabetes and hypertension. For normal, healthy pregnancy, you can anticipate just 3 ultrasounds. 2 of them you have when you first find out you're pregnant. First, is when we do your ultrasound to find out how far along you are and date your pregnancy. The second is when we measure the back of the baby's neck to look for anomalies. And the third is that 20-week ultrasound, which I'm sure most of you have had at this point with maternal fetal medicine, to have a very good look at all the anatomy of your baby. For most people, that's all that you need. GBS testing, we like to do this at 37 weeks. Group B streptococcus is very similar to group A streptococcus that you find in your throat, only B is what's likes to hang out in your vagina. For most people, this is not an issue, but for babies that have certain risk factors like prematurity or being in the uterus with the water broken for more than 18 hours, they can be at increased risk for getting this infection. And when they do, it usually requires a NICU stay and antibiotics. So it's the recommendation of the Center for Disease Control that all pregnant people are tested, and if positive, receive what we call prophylactic or just in case to prevent infection spread to the baby. A lot of people get concerned that they'll miss their window for, to get those antibiotics to keep babies safe. But optimally, we only need about 4 to 8 hours of antibiotics. Times when we want to start the antibiotics is when you're in active labor, so about 6 centimeters, or when your water breaks. We also like to start it because that barrier is gone. Next, we'll talk about common discomfort. And no matter who does this slide, we always seem to miss 1 or 2 or 10. So feel free to, turn your mics on and, send out a discomfort if we don't mention it here. But, there's a lot of discomforts. Can include things like indigestion, as everything relaxes from the relaxin hormone, and also that increasing pressure from the baby in the uterus. Things like Tums and papaya can be helpful for that. And on the other end of the spectrum, so to speak, constipation is another very common complaint. Stool softeners are completely safe to take in pregnancy. You just want to avoid stimulants. So anything that says stimulant on it for a laxative, you do not want to take because it also stimulates the uterus. But anything that's just a stool softener, things like milk and magnesia, colace are all considered safe in pregnancy. Fiber and hydration can definitely help with this. Common pains like round ligament pains or pains that are in the bottom portion of your belly and shoot down into your pelvis or legs are very common. Lower back pain from that shifting gravity, problems sleeping and staying asleep because you're peeing constantly, which is also another common complaint. What others do you guys have? Did anybody put anything here in the chat?
I guess Braxton Hicks. So practice contractions that go on. Yep.
Right. Yep. And to be very clear, if you're preterm, so this is before 37 weeks, and you're having more than 5 contractions in a hour window that don't get relieved by sitting down and resting and hydrating, then you would want to let us know. But for the most part, irregular Braxton Hicks contractions are a tightening feeling. Some will say it feels like a period cramp. Occasionally, this is completely normal. Yeah, the tightness in the stomach, those are Braxton Hicks, believe it or not. But as long as they're occasional and not regular, they're usually not something to be concerned about. Fatigue is definitely another great one. Like, you are working really hard to create another human being here. So you want to try your best to, rest when you can, stay hydrated, eat well, and know that you're not alone. Swelling in the feet or puffy feet, right? This can be very normal in pregnancy, but it can be concerning because when you Google it, you're going to see things like preeclampsia come up, and that can be very scary to interpret. So you can always talk to us about it if you're not sure, because we're the experts and we're here to help you. But the swelling with preeclampsia is typically like a 5 or more pound weight gain in a day. And you'll typically see swelling in your hands, face, lower extremities, and the edema or swelling in your legs does not go away when you rest. It tends to hang out and want to stay there. Usually with preeclampsia, that's also accompanied by headache, severe right quadrant pain or epigastric pain that doesn't go away with antacids or Tums, and a headache that doesn't go away with Tylenol. If any of those things happen, you'd want to let us know right away. Yeah, the papaya, some people with find papaya helpful for indigestion, but it's kind of 50-50 whether or not it works. I mean, I think if someone's asking about pressure on their left side when they're laying down, I think the general pressure that you would have when you're laying on your side it is acceptable. I don't think that you can overdo laying on your side. Does that answer your question?
Yes, thank you.
Of course. And then someone said something about leg cramps. You want to take one, Jen? It's a lot of complaints here.
It's funny when we start talking about discomforts, people start chiming in because this is hard. Miranda already said growing another human is a whole lot of work. So yeah, so tingling in your hands and feet, like a pain that shoots down one leg, or like some of your extremities falling asleep more often, especially if you're laying on that side. It all has to do with that increased fluid that you have. Like your blood volume increases about 50% when you're pregnant. So that puts more pressure on nerves. Your body has to work harder to return that blood up to your heart. So you definitely have more tingling, more more like things like feel like they're falling asleep, and then that swelling that we talked about. Somebody did mention something about having a hard time moving their hands in the morning. There's something called carpal tunnel of pregnancy. So like that extra fluid can make it where you're sleeping and your hands are still. When you wake up, it feels like you can't really move them. So braces on your hands at nighttime sometimes work. When you wake up in the morning, putting ice right here below your thumb can sometimes get that swelling right there in that particular spot to go down, which makes your hands easier to move. But in general, the best thing to do when you get up and start moving around is start moving around. So you get yourself moving, you get something to drink, you start doing some stretches to get things to kind of get themselves back in order. Yeah, because it does take a lot. Because once your body and you should be laying for a while at nighttime, but once your body is in one position for a really long time, you do have some soreness. There was another about some weight loss. As you get bigger, and as your uterus pushes up, the space that your stomach fills up, it just has less space. So it is hard sometimes to keep up with eating. You don't feel like you're very hungry. You feel like as soon as you start eating, you get very full. So some people, you need to kind of work on like more frequent meals and eating like, little bits throughout the day, as opposed to those 3 kind of, normal meals a day. But at the end of pregnancy, sometimes we do lose a little bit of weight, and that's okay. Your baby is probably still gaining weight. It's you that's, usually your body gives what it needs to the baby first, and you get what's left over, which is why we still encourage prenatal vitamins, encourage you to try to get those meals in there when you can, because it's you that gets what's left over. Okay. Redness and bruising on the abdomen. So babies can be pretty impressive in there and the way they move around. There's occasionally somebody who gets a broken rib because their baby pushes real hard in one area. If you have a lot of bruising on your abdomen, we probably want to see you, make sure there wasn't something else going on. I mean, obviously we're seeing you pretty frequently now. I don't think you need to make an extra appointment, but if you're getting a whole lot, and we do have sometimes our bellies look very different as they get really expanded. But if you feel like you have bruising in one particular spot, it should go away and it shouldn't keep coming up. And, if you do have a lot of that, we probably want to just check in, make sure everything's going there. And that
Sure.
pelvic pressure, right? That pelvic pressure is a definite one. As your baby settles down, to be head down and putting pressure down to kind of, into that pelvic area. The hormones of pregnancy do loosen up your ligaments, which is good. That pelvis has extra ligaments in it, so it actually changes shape and gets a little bit bigger. And that baby pushing down, you definitely get that pelvic pressure. So moving, yoga, some stretching, even sitting more on a yoga ball than in a chair, and less reclining positions, more forward-leaning positions can kind of help with that. But you really got to keep moving. I mean, it's all about moving. Like something's going to feel okay for a little bit, but then you're going to have to move around. There's questions about drinking. So any kind of liquid is good, whether it's ice water, crushed ice, if you like room temperature water. There's nothing about what kind of fluid that you take in, either hot or cold, that's going to be hard for your baby. Just like you can go swimming, so the pool doesn't have to be a certain temperature. We don't encourage hot tubs, but you can definitely be in cooler water or drinking cooler water. And when you're pregnant, it's not going to be harmful for you or the baby. I think we covered most of those. Okay. All right. Okay, so I'm going to ask real quick about spotting. So we'll head on to the preparing for labor after this. But spotting in the third trimester is not necessarily a sign of something to worry about. When we are pregnant, it definitely sometimes gets us nervous when we see some bleeding in pregnancy, and there's part of that on here. But at the end of your pregnancy, as your cervix starts to soften up, there's lots of little capillaries. So if you're doing just a little bit of spotting, especially if you've had spotting throughout your pregnancy, that might just kind of be your normal. We get nervous about bleeding that's heavy like a period. So if you put a pad on and you're soaking a pad, then we would get nervous if it's that heavy. But as your cervix starts to open a little bit, there's lots of capillaries in your cervix, so you might notice spotting. If you are engaging in sexual activity, which is perfectly fine unless you've been told otherwise, that's another time. So if you ever call and tell us you've had some bleeding, then one of the first questions we ask you is, have you engaged in sexual activity? Again, but that's just because the cervix has lots of capillaries. So if you are engaged in activity, you might have a little bit of spotting. It's not up where the baby is. It's not a concern for the baby. It's usually just your cervix, which is like spotting a little bit. Okay. Dawn, are you on? Okay. Well, yes. All right, I'll take this one. So preparing for labor. So a lot of people, this is a big thing, right? We talked about like the last parts of pregnancy, which can be really uncomfortable, and they really are. But what we're really looking for is how do we, as we get close to that, how do we get ready to get this baby out? And so we get lots of questions about, is there anything I can do to make this baby come sooner? Is there any, what are some safe methods to being really, really ready for pregnancy or for labor? And so there's a couple things you may hear or read about, so which we like to talk about here. And then also, if you have any more specific questions about it, because some things may be safe for you and some may not, we can talk in the office. But really preparing for labor, one, we like to tell you that there's not been one person ever that has stayed pregnant forever, okay? Although it feels like it feels like the very end, like you might be pregnant for the rest of your life, and every day is harder than the day before. Even if you do nothing, most people go into labor spontaneously on their own if left alone. So we only intervene and usually do stuff to bring that earlier if there's a good reason to. Things you might want to do to get ready is stuff like this. So preparing yourself with classes, kind of being, really ready for like what all it might, entail to bring this baby out. Also working on trying to get rid of some of the fear behind labor and birth, because fear can hold us back. So even if there are a lot of people say, I don't want to know, I'll just figure it out when it comes. But then when things start to happen and they're not familiar with it, they think there might be something wrong. So doing some preparation is really helpful, trying to really focus on the idea that you have done this beautiful job growing this baby inside of you, that you will be ready when the time comes. So your body will also know how to labor and how to birth. So working on letting go of fear, because fear can hold us back. Other things you can do is practice things like, working on making sure your body is ready. So the whole pregnancy, staying mobile, moving around, using things like the birthing ball, even practicing doing some lunges, So that practicing getting those hips really used to be more open than closed, because you do need to be able to move around, be able to like actually lay down and drop your legs out almost like in a butterfly position for things like your cervical exams and for laboring position. So you want to make sure your body is ready for this big event that's going to happen. Other things that you might hear about are things like dates, red raspberry leaf tea, pineapple. Those are things that you might be reading about. You might come up on your blogs that you're looking at, or any groups that you're part of. So we try to break some of this down for you to give you a little bit of like information that has some kind of like science and research behind it. Dates during pregnancy have really been shown to help ease labor and help you as you get into labor. Now, what happened is there's certain cultures that encourage pregnant women to eat dates when during their pregnancy, and they noticed that those women tended not to go over their due date, tended to show up at the hospital or their place of birth when they are really their cervix was more dilated and more open and more ready, and they were less likely to have their water break before labor started. So all those are really good things. So what we started, so they actually did a controlled research trial where they told certain people to eat dates and certain pregnant people not to, and noticed that they were able to duplicate those findings. So the recommendation is, to eat 5 to 7 dates a day, depending on the size of them, the size of the dates. If you get the really big dates, it's 5. If you get the smaller dates, it's like 7 dates a day, starting around 36 weeks. You can start sooner than that, but you don't need to, starting around 36 weeks. And that usually will help you hopefully not go too far over your due date. Hopefully, when you get to the hospital to meet one of us, that you're going to be more dilated, and that the goal will be for your water not to break before labor starts if we can help it. Okay, so that's the information about dates. We don't encourage it for people who are diabetic because dates have lots of sugar. So if you're diabetic, don't worry about eating the dates. Keep working on the other things we talk about, like being active. Red raspberry leaf tea has been something that has been used for a long time. I've been told it actually does help tone up that uterus. So helps that uterus, which is just a really big muscle, help it get some strength behind it. Some people notice if they start drinking it, they might notice a little more tightening and a little more Braxton Hicks than they had before. That's okay, as long as we don't get into into a pattern. So red raspberry leaf tea is just to help with starting, making sure your uterus, when it contracts well. Some people drink it for their whole pregnancy, and others again start really close to that 36, 37 week mark. Neither one is right or wrong. And if you were somebody who's really into science, the research behind red raspberry leaf tea is not as strong as the research behind dates. It has been shown to, not been shown to cause any harm, but it hasn't really necessarily been shown to be super beneficial. Although some people really like the taste, and if it can help you stay hydrated, that's really good. Pineapple is another one of those things. It's probably been only in the last 3 or 4 years that people started asking about pineapple. Before that, I never heard people saying we should be eating pineapple when we're pregnant. Not a whole lot of research in it. It is a good source of fiber. It's a good source of quick energy, that quick sugar. Still be careful with it if you're diabetic. It can't hurt, so it's not something that would be harmful. Okay, so those are some of the things that you can do. Other things you can do is make sure you're staying on top of being active, like we talked about. Big things people want to look at, ask about is that what signs? How will we know? How will we know if it's about time for that baby to come? So what are the signs that labor may be starting soon? Well, in reality, there aren't really a whole lot of great signs. If it's your first baby, you may notice that the baby settles down into your pelvis a little bit. You might, some people call it dropping. You might notice a little bit more space above your belly. You can breathe a little easier, but more pressure down below when the baby's kind of settled into that pelvis. So you might have to go to the bathroom even more often than you're going right now. So that's one of the signs that, you dropping. If it's not your first baby, that tends to happen a little later. So because once you start putting pressure on that cervix, then your body kind of remembers what happens here, and so it starts to kind of go into labor a little sooner. Other signs that you might be going into labor, so like lightning kind of feeling down in your down below. Some people call it lightning crotch, where they feel that sharp shooting feeling down below. Doesn't necessarily mean it's happening right now, but that's just more pressure that baby's putting down. As you get closer, you might be lose that mucus plug. Again, some people have had more than I've had 2 children and I never noticed a single mucusy thing coming out of me or a big mucus plug coming out. Others have this big blob of mucus that comes out. It looks kind of like snot. It can be big and very sticky, sometimes have some blood in it. Your mucus plug sometimes comes out little bits at a time. So that's why some people notice an increase in their discharge towards the end of pregnancy, and some lose it all at once. It's not necessarily a sign that labor is going to start tomorrow. It's usually a sign that labor will start in the next month. We don't need to be notified when you lose your mucus plug unless you have questions or concerns about it. It's just one of those things that just happens, over the course towards the end of pregnancy. And even if you're before a month before your due date and you lose it, it's not necessarily a sign that you're going to preterm labor. And there's nothing we'll do. So if you lose your mucus plug at 34 weeks, there's not necessarily anything we're going to do to change up the course of the rest of your pregnancy. You would just kind of watch and wait. Okay. Other signs, people do notice some nesting. Some people notice that they start having a day or two before labor. They might notice some loose bowel movements as their body's sort of trying to get things ready. But in general, signs that labor is starting soon is that you're getting further into your pregnancy and your body's getting ready, and you just have to kind of relax a little bit and just let things happen. We did talk about if bleeding was ever okay when you're pregnant. So it can be in that 3rd trimester. We don't want you bleeding heavy like a period. So if you have a little bit of spotting that you notice when you wipe, or even a little bit staining your underwear, but usually if you start to see any, we tell you to put like a panty liner or pad on and then watch it. If it starts where that whole thing is filling up, we definitely want to hear from you. Other than that, it's probably just a sign that things are starting to soften down there. And then the last question on here is like, what happens if your water breaks before contractions start? And Miranda talked a little bit about the GBS swab. So that's a really important factor about your water breaking. If your water breaks and you've already done your GBS test and it is positive, then we want to hear from you because we need to get you to the hospital to start your antibiotics. But if your water breaks and you haven't started contracting and you're over 37 weeks, so you need to be full term, anything before 37 weeks, more than 5 contractions in an hour or water breaking before 37 weeks, we definitely want to hear from you. After 37 weeks, when you're considered full term, starting contracting on your own, you can start kind of trying to time those, try to figure out what's going on. And we'll talk a little bit about labor on the next slide or two. Or if your water breaks and your GBS is known to you and you know you're negative, you don't have to call right away. You can certainly let us know if you would like to. What we know about water breaking is when your water breaks, it releases a lot of prostaglandins, which is one of the hormones that your body uses to soften up the cervix, to get things ready, and to start some of those contractions. So if you're GBS negative and your water breaks, 94% of people will go into labor within 12 hours, and up to like 97 or 98 will go into labor within 24 hours. So if you're looking for that low intervention, not a whole lot of medication kind of birth, and your GBS is negative, we would encourage you to stay home and try to see if your body kind of gets the idea and gets things started. We are fine with you staying home for 12 hours. If you really want to, up to 24. The big thing is once your water breaks, nothing in the vagina after that, because we know that the chance of infection goes up more with how many times something goes into your vagina, so how many times you're examined, than how long it is between when your water breaks and when you deliver. Don, you want to take this one?
Sure. So now we're going to talk a little bit about labor, what to expect. So labor is, when you start to get contractions, and it will not only thin your cervix, but also open your cervix to have your baby. What is normal labor? There's a whole bunch, everybody's labor is different. It's very difficult to know when the best time to tell you to call. Well, we tell you when to call, but the more challenging thing is our shared decision making on when's going to be the best time for you to come to the hospital. We do have some, things where we definitely know you should come sooner than later, but beyond that, it can be, challenging, and we talk about it to find out when. Of course, there's different stages of labor. The first being your cervix actually opening, and the second being you pushing your baby out, and third, kind of coming out, and fourth is your recovery. So again, we talk to our patients a lot, some a few times before we actually decide for you just to come in to perhaps get a cervical check. And if someone's really apprehensive, I always, just share with them that they certainly, the worst that can happen is everything looks great. And then we decide for you to go home for a little bit longer. And there's nothing wrong with that. It's nothing to feel bad about. And again, there's only so much we can do when we talk about it over the telephone without actually assessing you. The number to call is the office number that you always call. That number is always going to be the same. There's always a midwife on call 24 hours a day, 7 days a week. And the service outside of office hours will text us, and we will call you back as soon as we possibly can. Sometimes we are in a delivery or attending to something else. It might be, a little long, but it shouldn't ever really take us more than say 20 to 30 minutes or so to call you back. It's usually pretty quick. Available ways to manage pain. We certainly, encourage you again to stay home as long as possible. Home is a great place to be in early labor, where you can eat and drink what you want, be in your own bed, shower, tub. But once you're admitted to the hospital, there's some definite ways we can help you to manage labor pain. There's nitrous oxide, which is like a gas that you inhale via a mask, kind of like similar to what you would do at the dentist office. We have IV sedation that we can give with a couple different things, one of which is called Nubane, and a lot of times we give that along with Benadryl. Epidural anesthesia, of course, most of us most likely heard of, and that we try to, wait as long as we possibly can, because once we get an epidural, we can't get out of bed, you can't eat, I usually lose the ability to go to the bathroom on your own. So it's kind of, we try to hold out as long as we can with that. And then the ways to monitor the baby, most times, you get coming to the hospital, the nurses, we put you on the monitor. There's one piece of the monitor that listens to the baby's heart. The other piece monitors the frequency and the duration of your contractions. And that's the most common thing we do. If you're low risk and you're in labor on your own, the baby looks good, there's a definite possibility we can do some intermittent monitoring, get you off that monitor so you can be free to walk around the room, get in the shower, stuff like that. Sometimes in labor, we need to do a few things to try to give you the best opportunity to have a vaginal birth. Internal monitors are used when we are having difficulty keeping your baby on the monitor from the external way. And there's a little electrode that sometimes we will gently place in the baby's head to monitor very well, particularly if you wanted to push on hands and knees and the baby was again showing us signs that we needed to watch the baby a little bit more closely. Also during labor, sometimes the baby needs some cushioning replaced around the cord. So we put in an internal monitor and actually put some fluids back around the baby to cushion the baby. And again, these internal monitoring are done only when absolutely necessary, and more than likely because, again, we're striving to get a vaginal birth. Sometimes we're successful and sometimes we're not, and then we proceed with the C-section. So I'm not sure, I guess Nikki's been monitoring the chat box there. I think we covered, I don't know if anybody else, I think I covered most of it.
Yeah, the chat box has been very busy.
Yeah.
Nikki and Jen have been doing a good job keeping up on it, I think.
Yeah. Yeah, the phone number, yeah, see they're going through some stuff here. Some of this stuff, yeah, go ahead.
Can everyone hear me?
Yep.
Okay, perfect. I have issues with my speakers. Okay, so benefits of early labor at home. So as you know, we've kind of been talking about a little bit here. As long as we've talked to us, we feel like things are going well, your GBS is negative, otherwise uncomplicated pregnancy, we know that the research shows and tells us that laboring at home in those early stages are very beneficial for a lot of different reasons. As you can see on the slide here, are just some of them. You're more comfortable. You're in your own space. You're in your own environment. Someone just mentioned about tubs. We'll touch briefly. There's one tub in the hospital that's in the middle of like the rooms across from room 9 and 10. And if you need to be monitored, continuously for whatever reason, it's really hard to do. We try to honor your wishes, but it is pretty hard to do. There are showers in every room. So if that's something that's really important to you and it really works well for you because it can help with pain reduction and that discomfort, then, it's really beneficial to be at home in those early stages as you're kind of working through them. You have your own space, you have what you like, you can move freely. We can't walk the halls in labor in the hospital. So there's a lot of benefits as far as comfort being in those, being at home. You have your own bed, you're not in a hospital bed, things like that. As you're resting in those times, you have a freedom to eat however you wish, either in the hospital or at home. So you can nourish your body with the foods that you enjoy versus like, what do I have to pack and bring and think about those things. And there's less distractions. We're not in there. Oh, we got to monitor baby. Oh, baby's off the monitor because we have to do something. We have to monitor again. We have to check in, see how you're doing. Dietary's rounding, the nurses are coming in, doing their rounds, we're checking in. And, there is some benefit to us being there and being present with you. But in those early stages, before you're getting really super uncomfortable, less distractions where you're not thinking, oh, I am contracting. Am I contracting enough? The nurse thinks maybe I'm not. Am I? Maybe I am. Maybe, you can have that freedom to just kind of be distracted, be around, in your comfort zone, and have that and more freedom. Like we talked about, you can roam around, you can go outside and take a walk if you're at home, be with animals or your kids. We don't allow anyone under the age of 12 in the hospital right now. So, being around your other children at those early stages can be really helpful for you as well. And your labor progresses better, right? You're able to just kind of forget, maybe do a little bit of dishes or maybe, rest on your couch and then move to the bed and then being able to squat a little bit, on the stairs or something like that. You have that freedom. And the research shows that when we are at home and we're utilizing those benefits of being at home, your C-section rate, your cesarean rate, your risk of having a cesarean is lowered. So all of those things can be really helpful. Jen did an excellent project on this. And so if you're ever in the Lawrenceville office in room 2, there's actually a poster of kind of the research that she did. So take a look at it someday if you have the time, if you're in that room. Okay.
Miranda, you're up for the long slide again.
Oh, yay. Yay. All right. Okay, so let's talk a little bit about, hold on, messing up my laptop here, about induction and other interventions. So why would we recommend inductions? There's reasons. I think like we touched on before, we do not do elective, which means for no reason other than we choose to, or that you want us to, inductions in our practice. And the reason that we do that is because we've done a lot of research headed by Jen as part of her doctorate program on elective inductions and on decreasing our C-section rate as a whole, both for our practice and for our hospital. And we found that doing elective inductions increased our C-section rate statistically significantly. So that is why if you hear other people that you say, oh, my doctor said it, I'm 39 weeks, why not just induce? That's why we don't. When we do have to do inductions for reasons like being overdue, which is over 41 weeks, is between the 41 and 42 weeks. The 40th week is just your due week. You have that whole week before you're considered post-date or overdue. Having diabetes, hypertension, these things when they're uncontrolled, and it's recommended in collaboration with the doctors and maternal fetal medicine specialists that we induce you early. If there's concerns about the baby and the baby's growth. And there are other reasons too that we'll discuss with you on individual basis, of course. But when we do need to do an induction, it's important that you understand that it's a lengthy process. It can take 3 or 4 days before you see your baby and have your baby in your arms. And this is because before we even start the actual induction process, where we give you Pitocin to mimic contraction and bring on contractions, we may need to use medications like Cytotec, Cervidil, or cervical ripening balloon to help ripen the cervix. So that way, when we do start Pitocin, we're not setting you up for failure. The Cytotec is a pill that you take every 4 hours for up to 6 doses. So you can see where that takes up about a day right there. The Cervidil, if we need to go to that, is a string of medication that sits behind the cervix in your vagina and sits there for 12 hours. And a cervical ripening balloon can be given with Cytotec or with low-dose Pitocin and can stay in for 12 hours as well. So you can see there, that's just the ripening phase before we get to the actual induction process. And you can see why, if you are having an induction, probably, especially if it's your first baby, probably a good idea to bring board games, food that you like. Expect to, have a little baby moon in the hotel room, or like you're in a hotel room in the labor room before you have your baby. Be patient and calm, because we're always more patient than you. We're not going to rush you in any way. We're going to have shared decision making. And present, all the evidence and educate you to make the best decisions about you as this process goes on. Like I said, once your cervix is ripened for a first-time mom, that's a Bishop score of 6. For a second-time or more parent, it's a Bishop score of 6. For a first-time mom, it's a Bishop score of 8. And this is a calculation that you can Google if you want, but it's based off of the position of your cervix, the position of your baby in your pelvis, the texture of your cervix, the dilation of your cervix, and the effacement or thinning of your cervix. And we know if we use this calculator consistently, we help to reduce your risk of C-section. Other interventions are included here. When you are having most of these induction agents, it does require what we call continuous fetal monitoring. But we're very lucky, in almost every room here at the hospital, we have what we call wireless monitoring, that they sit on your belly and monitor the baby, but you're not tied to the machine or the bed. You can still get up, walk around, and have that freedom of movement. If for some reason we're not able to monitor the baby successfully, sometimes this can be an issue for larger birthing people, or premature babies, or if there's a lot of fluid, or sometimes maybe you just want to push in a hands and knees position and we're just not sure that we're safely monitoring the baby. We might ask to break your water if that's not done so already, and use an internal monitor, which is a clip that goes onto the top of the baby's head. So we're directly getting baby's heartbeat. Like I said, this is not routinely used. As a matter of fact, none of these interventions are routine per se. We're going to always, like I said, discuss them with you, have that shared decision making, and come to the best conclusion of what works best for you. Sometimes we may ask to break your water to help, because some of the evidence shows us that it can speed up your labor, but it's not something that we have to do. So we can have a discussion about that, of course. If your baby is showing signs that there might be some cord compression, we also have another catheter that we can put in to the uterus through the vagina that does 2 things. It tells us the true intensity of the contractions, because we can't really tell that by the external monitor. And it also allows us to put fluid back in to help cushion that cord if we need to. Episiotomies are something we definitely don't do enough of. Actually, by the healthy people standards, we don't do enough. We always ask consent before doing one. You'll never have a surprise episiotomy like you may have heard your mothers or grandmothers received. Reasons that we might do an episiotomy is if the baby's in distress and we need to expedite delivery. I would say the most common reason that we do episiotomies is for something called a shoulder dystocia, where the baby's shoulder is stuck behind the pelvic bone. And many times we still have plenty of room to get our fingers in there and help to twist baby or deliver the baby's little arm before the rest of the baby comes. But every so often we just need more room to get baby out safely. And so we'll ask you to do an episiotomy to make more room for what we call the maneuvers to help release that shoulder dystocia if it was to occur. The last intervention on the list is a vacuum assisted delivery. None of our physicians do forceps. So that's not something we'll discuss here, but a vacuum assisted delivery is more like a suction cup. It's not to walled vacuum. It's placed on the top of the baby's head to help expedite delivery. The reasons that we might offer this to you is for maternal exhaustion, which means, you've been pushing forever and you just need that extra help, or because the baby's in distress. This is a more common reason and we need to expedite delivery. Again, these are not routine and they're not without risk. So, we'll always discuss the risks, benefits, and alternatives of everything that we recommend for you to do. And like I said, and I think you'll hear us say 100 times before, like I always hear pregnant people say, am I allowed to do this? Or can I do that? Or will you let me? This is your body and you're the ultimate one responsible for making decisions for you and your baby. Our job is to educate you with, the evidence and for you to make the decision on your own while being able to ask us whatever questions you need to get the information you need to make a decision.
So there were a couple of questions in the chat box. I know it's a lot. You did a lot there. There are a couple of questions in the chat box about membrane sweeping. And so we didn't have that as on the under induction, but it is really an inductive method, right? So it's a method to help start labor. There are times where we actually might even recommend or offer it more freely. And that's if you're like facing an induction. If you're a diabetic who we know you need to have your baby by a certain time, or you're getting close to pregnancy, we might start talking to you about what a membrane sweep might look like and what are the risks versus the benefits and alternatives to doing it. Nikki explained in the chat box that it really is, it involves a cervical exam. So we would actually do in the office, we check your cervix to see if it's open. If it is, we can go through your cervix and try to take that bag of water the baby's sitting in and separate it from the wall of the uterus. It helps release prostaglandins. The biggest risk associated with it is breaking your water. It doesn't happen very often, but it could happen. And then we actually then have to make the labor happen. And then, one of the other risk is it causing some cramping and some kind of contractions and a little bit of bleeding, but then it just peters out and nothing happens. It can be an annoying afternoon for you and then it kind of peters out. Sometimes having more than one membrane sweeping, can help you, especially if it's going to be your first labor. So doing it like at 39 weeks and then again at 40 weeks might help you get into labor more quickly. So that is something that we talk about. There's some good research on cervical, on the membrane sweeping and also cervical massage, so that if we can't even get through your cervix to do the sweeping where we try to separate that bag, actually massaging your cervix can do some of the same things. So that might hopefully can give you some. That's one of those things that we can do and send you home, as opposed to all these other things that Miranda talked about that would have to be done at the hospital. That answered that question. Now we're getting more into the whole birthing part. So here's some pictures of some different positions we can get in. We'll kind of talk about it as we move forward, and then the end product over here on the right side with what you're all striving for.
All right. So the truth about pushing. So when to start pushing. If you've had a baby before, you may have you have experience with this. This looks different for everybody. So there's not some cookie cutter mold of like, you're at 10 centimeters, we need to start pushing. If you are on an unmedicated birth, you will definitely have more of an urge than some other people that have an epidural. You may have some spontaneous bearing down, especially if this is not your first baby. Things may look very different from your first or even your second. So we're really waiting until If you're unmedicated, you're kind of having those urges, you're having those, those bearing down. It's almost like you feel like you have to poop. That tells us that you are probably 10 centimeters, which is the definition of being quote unquote fully dilated. And technically ready to push. You're 10 centimeters, the baby's head is nice and well applied. If you are unmedicated, we really are waiting for that spontaneous urge. You could be 10 centimeters, but if you're not having really great urges or really wanting to bear down, then we're just kind of continuing to labor with you and encouraging positions that be in until you're really feeling that urge. If you have medication such as an epidural is what you would typically have when you're fully, at the point that you're fully dilated. There are other medications you can take in your labor, but an epidural is typically what you would have when you're fully dilated at that stage in labor, because we wouldn't recommend some of the other ones. Nitrous oxide is available that you can have, but doesn't have a long effect on it. There's IV forms of sedation that typically we don't give if we think you're going to be pushing soon, because they can make the baby sleepy. But if you have an epidural, you don't always have that urge to bear down. So we really will wait. There may be, we may have to check to see if you are fully dilated. We may have to do some of that, but we're really waiting. If you have an epidural, you don't typically feel the contractions, but you will still feel pressure. Most people, some people have a really what we call dense epidural and they feel absolutely nothing. And they don't feel of that. But most people, because we want you to have some of those feelings, and especially some of that feeling of pressure, because we want you to be able to kind of help bear down to bring your baby into this world, because there's some work that has to be done, especially if it's your first baby. So they'll feel like you have to poop. We hear that a lot with people that have epidurals. They're like, I feel like I have to poop because of, everything is so close down there. So some of those, you have those similar feelings. Now, as far as pushing positions, there is not a standard, okay, it's time to push on your feet in a stirrup and laying on your back. We don't encourage the single lithotomy typical pushing that you see on TV. We will encourage multiple different positions. A lot of times, again, if you're unmedicated, you naturally put yourself in some position that feels good for you, and we will leave you there. If you're laboring down a little bit and you're not quite in the pushing stage and you're sitting on the toilet, then we might have you backwards on the toilet, just kind of, that's okay. We'll do those with you. If we think it's getting close to delivery, we might, time for your birth, we might, have you try to get you towards the bed. It's a little bit easier. It happens where it happens, but, for sake of birth, we try to have you closer to that bed. The nurses sometimes panic. So we try to kind of honor their wishes a little bit on that side, but hands and knees on your side. If you're pushing more than just a short time, we will encourage you to change positions because that will help with fetal rotation and bringing that baby down. So you can push in all sorts of positions. If somebody's pushed for a long time that's in this chat, they would probably tell you that. We can use a sheet. We have a squat bar that we can use. We can put the foot of the bed down and the other bed's up. We can sit you up. We can lay on the side and support your legs. So there's a lot of different positions that we encourage you to be in versus being on your back and pushing with your legs up. How long will it take? Again, it varies from person to person. If it's your first baby and you have an epidural, it can take over 3 hours pushing with your first baby. So we utilize that whole picture of where are you at? How do we feel like your dilation is? Should we labor down a little bit more, where we're just letting passive descent of that baby? We're letting that baby come down without you doing a ton of pushing work, because we know it can take a few hours with your first time pushing. And some first time moms can do it in 10 minutes. It all varies. It all varies on fetal position, maternal effort, and just, the pelvis. So there's not a one size fits all answer for this either. If it's your second baby, it usually takes much shorter time. And will I tear? That is the question that we hear very often. We try to reduce tearing while you are in that pushing phase by putting warm compresses on the perineum, by not having you just quickly push a baby out as fast as possible to set a record, by, having that slow controlled pushing as the baby's crowning, maybe having you breathe through the end of that so we can help all of that stretching and let that skin stretch out versus quickly and tearing. If the event, like Miranda talked about, we do not do episiotomies very often. If we believe that it would affect your tearing of your bottom, and it might be safe, better, quote unquote, better for you to have a slight episiotomy. So a tear will go one way versus if we feel like your body would tear a lot if we didn't, then we would recommend that, and that's something we recommend. But again, it's individualized and it's consent based. So we don't just do that without letting you know. Delayed cord clamping. So if everything is going fine and your birth happens and your baby is crying in a natural event, that the spontaneous birth, 3 to 5 minutes typically, or when the cord stops pulsating, is typically how we will do delayed cord clamping. We will leave that cord right attached with that baby right on your chest or your abdomen, depending on if you have a short cord, and the baby will stay there. We'll wait till it stops pulsating before we clamp the cord. And then we will offer, if somebody would like to cut the cord, whether it's you or your partner, whoever's with you, would like to cut that cord. We can take pictures if you would like to take pictures. We can do any of that. The nurses are more than happy to help, with photo taking if everything's going fine, and they can attention to that. If for some reason we have to have the neonatologist come in, there is a NICU in the hospital, which I'm sure most of you know. So if there's events where, baby's having decelerations, or there has to be a neonatologist in present, and it's important to have that baby assessed, we will try to do is cord clamping as long as possible, but the baby may need to go to the warmer for an evaluation. And that warmer, if you're laying there, the warmer is right, within hand distance to you. So even if you give birth and we have to just put the baby for an assessment, you still can see the baby. It's right there. Your partner can just turn around and the warmer is right there, because your birthing partner will be between the bed and the warmer. So they're right there for both things. So they're there for both of you. And then once, the baby's fine, they've determined the baby's okay, it will go right back to your chest. And then delivering the placenta. After the baby comes out, then the next thing we have to do is pay attention to the placenta. Most placentas come out without issues. We have a good 30 minutes for that placenta to come out, and most come in the first 10 minutes or so. So we're really waiting for signs that the placenta is ready to come. Your cord will start lengthening. You might have a little gush of bleeding. We don't force the placenta out. We're not yanking on that placenta. There may be times where we just have to do gentle traction, like if you're having a lot of bleeding, or we just kind of need to check on the placenta because it's been a little while. There may be some gentle traction, but there's no pulling, there's no forcing of the placenta to come out. Questions there? I think there was a question about labor. Yep, 2 people, Jen just answered that. There's 2 people allowed for you during your birth that don't switch out. So postpartum, there'll be 2 that can't switch, but we'll talk about that. We have slides for that as well.
Going to discuss some immediate postpartum period and the golden hours after you have delivered your beautiful baby. Okay, so what to expect now that you've had your baby, hopefully baby's on your chest, skin to skin, and everybody is just soaking in the moment and enjoying, this moment. And the benefits of skin to skin, there's been a lot of research done. It actually promotes the baby to have an easier transition, such as temperature control, breathing, their heart rate, even their blood sugars, because they're less stressed. They tend to not cry as much. They're next to their mother, and they're nice and warm. It enhances bonding. It's a great way to establish breastfeeding if you've elected to do that as your choice for feeding. And actually, some studies have even shown it can reduce postpartum depression. So unless there's, a concern, or the neonatologist was there for a reason, where the baby would have to briefly go to the warmer to be assessed. Mom and baby and significant other all stay together for the first at least hour, hopefully after birth. Again, the nurses are, in the room very frequently. They will be assessing you during your postpartum period, which, after your placenta comes out, that first couple hours is actually a stage of labor. So they will do frequent blood pressure, vital sign checks. We will be checking your uterus, your bleeding. You know, we may be doing a repair, you know, with some stitches for you during that time, but all of which, you know, you can be with your baby. You know, the normal newborn appearance, we will review that. It is normal for them to have, you know, their little hands and feet may be blue, you know, but the rest of their body is pink. That's normal. The little hearts are, you know, literally going through all sorts of transition in their lungs and their breathing. So it is quite normal to see that. You know, they might have a little bit of nasal flaring a little bit initially, particularly in the first like 10 to 15 minutes. But basically, you know, as your healthcare professionals, we've seen a lot of deliveries, and we usually, you know, can just glance and know that everything is going well. And the nurses are excellent at sharing and teaching during that immediate postpartum period time. First feed, hopefully, you know, if you're breastfeeding, you're doing that within the first hour. Certainly, it could be within the first 30 minutes, but definitely we strive for within the first hour, at least trying to get the baby to suckle and just kind of, you know, get towards the breast. It's not more than likely going to be this, you know, dramatic, like, you know, proficient feeding, but we're not expecting that. And we're certainly there to help you with that. The nurses will discuss with you about newborn medications such as vitamin K, which is for blood clotting, and also the antibiotic eye ointment to prevent infections of the eye, which is the erythromycin ointment. They usually delay that a little bit, at least after, you know, the first hour, which is optimal after that initial bonding period. And the vitamin K, particularly with the newborn boys, you know, with the circumcision and such. And you stay in the labor room for 2 hours, after which everything's well. The nurse will help you get up to the bathroom. We'll do some peri-care, and then you'll go over to the postpartum side. So I also gently share with, you know, if you have some things that you're bringing into the hospital, try to kind of only bring up at the time, maybe what you're going to just use in the labor room, and save, like, you know, the breastfeeding pillow and some of these nicer kind of items for like after you move out of the labor room, because the labor room isn't really that big and it can just kind of take up space, and it's more for you to kind of take between units. So, and that's pretty much what you expect. Anybody okay?
So this kind of sums up some of the stuff that we've sort of been talking about, you know, so far and during the talk. And these are kind of the 6 healthy birth practices that are put out by Lamaze. But it's not Lamaze like what you saw when you started, like, you know, back in the day when people were, you know, really concentrating on the. It's really the things that we know that are going to help promote the best outcomes for families. So in general, we say let labor begin on its own. And so that's one of the things we've already talked about, that we don't do inductions unless they're medically necessary. When they are, we know how to manage them, and we are patient, and we will take the 3 days that sometimes it takes to get babies out. But spontaneous labor tends to progress better. So we like to let labor progress on its own. We talked about changing positions and trying to keep things moving. The more you move, the more your baby moves and settles down, so it comes out. You know, it kind of gets that pressure on your cervix to make things happen more. We also know that labor progresses better when we change positions. So we are encouraging you to change positions about every 5 contractions. For sometimes if you're in your home and your contractions are 20 minutes apart, that means you can be in a certain position for a while. But when you're getting closer to active labor and your contractions are every 3 to 5 minutes, that is changing positions frequently, but that's kind of what your body needs to get that baby to kind of rotate and come down. So changing positions and changing from laying down to sitting up to squatting to being on your side. Well, the more you move, the better. So changing positions frequently. We haven't talked a lot yet about continuous labor support. And sometimes people who don't know a lot about midwives don't understand the difference between what a midwife is versus a nurse versus a doula, and why you might want or need any of those things. Midwives are providers who see you in the office and also are there at your delivery. We love to be with you, and as much as possible, we are with you during your labor, but we also know that when, we're a decently busy practice. So right now Miranda's at the hospital and she's popped in and out of that room a couple times because I think she has 3 people, I think it's 3 right there now in labor. So she cannot be continuously in the room with somebody when she's got 3 people to kind of be with. So we are not your continuous labor support. Your nurse at the hospital usually only has 1, sometimes has 2 patients, but they are monitoring all kinds of things. They're monitoring the baby's heartbeat. They're looking at your medications. They're doing all kinds of charting that has to happen for the medical legal kind of aspect of your labor. So they are there to make sure you are safe and to give you as much support as they can in the context of a nursing role. But continuous labor support really are your support people. That can be your partner, can be the person you've chosen to be there with you. It could also be a doula. So a doula is someone that you hire, that you kind of do some research. There's a great website called doulamatch.net where you can put in some parameters of things that you're looking for. And there's people who will actually come to your house and labor with you at your home and then transition with you to the hospital. And they really are skilled people who have education, training, and lots of experience being with laboring people, and can be that continuous bedside support. They are not medical, so they're not going to answer your medical questions about inductions, about medications, but they are good at helping you about changing positions, reminding you to eat and drink, engaging your partner and things that can help you, manage your labor pain. So if you're thinking you might want an unmedicated birth, a doula is a great aspect. If you're trying to VBAC and you've not done a whole labor before, all the way to the end and push the baby out, a doula is an excellent support. Even if you think you want an epidural, we don't get epidurals with our first contraction. So we have to figure out how to manage our expectations and what labor looks like and what the pains may be. A doula is an excellent support. So there's not a person out there that we say a doula doesn't make sense for you. Doulas are a great support for you, have shown to increase your satisfaction with your birth, decrease your risk for a C-section, decrease your need for medication. So continuous labor support, and doulas are allowed and they're not considered in your number as far as the number of people you're allowed to have at your bedside. We've already talked about interventions, and there is no intervention that we say should never be done, but what we do is we try to tailor interventions to the people and to the things that are needed. So we avoid routine interventions. We don't routinely do anything. Everything is based off of you, your pregnancy, your birth, your labor, your wishes, how things are going. So everything is a discussion, everything. So if you ask us, what do you think I should do? Our answer is, here are your options. Here are what we think might be the best way to get you from here to having your baby the fastest way possible. But here are the risks and benefits of all those different things. And we don't do anything routinely. And then we also want you to have upright and spontaneous pushing. Nikki talked about that when she talked about pushing, that we want you to feel the urge to push and bear down with that. So we don't want to have to be standing bedside with you saying, okay, now a contraction is starting, let's start pushing. We really do want you to feel that urge, because if you don't feel it, then you won't be able to direct your body to push down in that right space. So, and upright is great. We like, squatting or sitting, and we like all kinds of upright positions, but really pushing in the position that makes sense for you is what we're looking for. And then Dawn really talked about that, keeping you and your baby together those first hours postpartum, where your baby is skin to skin with you. And even during the whole postpartum stay, having your baby with you actually helps with your figuring out their feeding cues. You actually usually rest better when your baby is in your room with you. So we try to keep families together, because that has been shown to help, all of the family transition to that time when you're about to leave and take that baby home with you. Oh, Miranda, the long slide again. It's your turn.
There's a slight chance I might have to pop out again and just have a baby that I'm watching here on the monitor. All right, so what if you need a C-section? So no matter how hard we try, to have a nice vaginal birth, sometimes cesareans are necessary, and we're very good about doing them and doing them quickly when we need to. Or your reason might be because we already know that your baby's breech, or because you've had a C-section before and are choosing to have a C-section again. That'll be a more scheduled thing. But even in a what you may hear as an urgent or emergency C-section, things move very fast, but we're very much in control. And we know that you have less fear when you're when you have knowledge. So we want to make sure that we share all this with you. I think we've touched on a lot about why what we're doing to reduce the C-section rate as a whole. It's having midwives attend your birth, having you labor at home in your own environment, not doing elective C-sections, having thoughtful discussions with you using evidence-based information so that you can make a shared decision with us about what's best for you and your baby, and following guidelines, which are always data-driven and evidence-based, which means that people have really looked at the numbers and the science to really determine how to get the best outcomes. So let's say for whatever reason you do need to have a cesarean birth. The prep often happens either in your labor room if it's unplanned, or in a room set up designed for getting ready before going to the OR if you're scheduled. Prep might include shaving the bikini line. There's better visualization, or clipping rather. It's not shaving the hair all the way down, but just clipping for good visualization. And then first you have an IV started if there's not one in place already. You may have a catheter placed in your bladder if you already have an epidural. If not, we'll wait until you're in the OR and receive pain medicine before we put that in. So that way you don't have to feel that insertion. When we're ready, usually the nurse and the anesthesiologist will come in and introduce themselves and go over consent with you beforehand. We'll bring you to the operating room. Now, the operating room will be covered in a lot of blue things. That's how we designate our sterile fields. We would ask the support person when we bring you in, a short time after we bring mom in and get her set up, that you try to avoid touching these blue things. The longest part about having the cesarean birth is actually putting everything back the way we found it before the baby was born. Getting the baby out is the quick part. So like I said, we will, the doctors will always ensure that you are completely comfortable and that you're not feeling pain before they proceed. The anesthesiologist and your support person, you can bring one support person into the operating room with you, will be up by your head. Typically, we have a blue drape to protect contaminants into the wound. However, if you would like a clear drape, you can ask for one. So that way, if you're someone who wants to see your baby being born and, is not easily bothered by, a surgical area, then that's something you definitely just let us know ahead of time so we can set that up for you. Then, once baby's born, the neonatologist will take the baby from one of our obstetricians, look the baby over really quickly. Usually babies that are born by cesarean birth need a little bit more suctioning because they haven't had the squeezing of the vaginal canal. And then they'll bring, when they've done this, they'll bring baby up to you, and either your support person can hold baby or, if there's nursing staff available, can help you to do skin to skin. If that's something that you're interested in, you can definitely ask about that. If not, and a lot of birthing people choose to do their skin to skin right after they come out of the operating room when they're a little bit more comfortable and able to sit up a little bit. And that's still within the hour and still tends to do all those great things you hear about when you read about breastfeeding and initiating bonding and things like that. Medications that you will receive, you'll have either the epidural that you have in place if it's unplanned and you've had an epidural already, will be bolus with extra medication to make you more numb. If you haven't had an epidural, a very similar, what we call a spinal, you may hear us say, is an epidural without the tubing left in place. And that'll give you enough medicine to last through the entire case. You'll be numb from about just above the belly button down to your toes. So like I said, you'll be completely comfortable, and we, don't start if you are. You'll receive oxytocin through your IV. We also have a ton of extra medications we could give you should you become nauseous, or anxious. So all those things, like once the baby comes out, we have a much broader amount of medications that we can give you. And then once baby's out, the doctor will, take their time to close all the layers and put everything back. The incision that you have is usually just over the pubic bone. and about that long, about about the size of a baby's head. They don't need to make it much larger than that in most cases. Right before you leave the OR, your partner and your baby will be taken to the recovery room, where they can definitely do skin to skin, as we just get you cleaned up and moved over into your bed to bring you to the recovery room. You'll expect to recover in labor and delivery for about 2 to 3 hours, just the same that you would for a vaginal delivery. This is when you do skin to skin. You can initiate breastfeeding. And the only thing that we ask is the same for an epiduralized person who has, that you don't get out of bed until anesthesia is worn off, and that you have a nurse present the first time you get out of bed, so you don't have an accidental fall. We'll make sure that your pain control is in a good place. And then once all these things have been met, we'll wheel you to the postpartum floor, and which is just down the hall on the same level. So, a lot of mamas will ask, what if baby needs to go to the NICU? It's still all here right on the floor. You're not going to have to take elevators. You're not going to have to take stairs. Your baby is readily accessible, just short while after. And we also now have the angel eye cameras. So even if your baby does need to go to NICU, for whatever reason, let's say that their C-section was because we needed to go quickly because baby was in distress, and now baby needs some observation in the operating room. In the NICU. From the operating room, you have the angel eye camera, and you and whoever you designate can see your baby 24 hours a day via your cell phone or camera or computer. But it is very secure, so that only you see your baby. You can expect to stay 1 or 2 days longer, so 3 to 4 days after a cesarean section, and you can expect to see the obstetrician round on you instead of the midwife, because you've had surgery. They're the more appropriate person to check in on you.
All right, the postpartum stay. Lots to learn before you go home. So after, we talked about after you've given birth, whether it be vaginally or via cesarean, you will transition over to the postpartum side. And that's just one big side that, doesn't matter. You get whatever room is available at that time. They may try to do them. I never really thought about it, but maybe they try to do them in one areas or not, but I don't believe so. But that's fine. So if you have a vaginal delivery, you can anticipate that you'll probably be there for about 2 days. If it's a C-section, you might need it a little bit longer, about 3 or more days. And so while you're there, you'll be rounded daily on a provider from Delaware Valley. If you've been with the midwife for your vaginal birth, we will round on you. If you've been a vaginal, attempting a vaginal and a needed a C-section, you'll be seen by the one of the physicians and at the practice, and we may try to round on you as the midwife, just to check in, see how you're doing, and see if we can answer any questions, because we were there for you for part of it. So we still like to, be a part of your care postpartum. Breastfeeding support. We do, a lot of the nurses are trained in lactation, and they do have lactation consultants that round on you every day. Sometimes multiple times a day, depending on what you need. They are available. What's nice about the hospital is that even after you go home, you can still consult with the lactation postpartum. So you have questions or something, you can call them. It's not that you can go back to the hospital, but you can call them. They give you a number when you go home if you're breastfeeding, so you can call with any questions. They give you a list of support, who you can reach out to if you need help, because there's lots of lactation. And we'll talk about, when you're treating a pediatrician, one of the things, if you're not sure about lactation, is ensuring your pediatrician's office has lactation support, because that can be really helpful and a really important piece of postpartum is breastfeeding and feeling supported. Siblings, no one under the age of 12 is allowed in the hospital at this time. Just saw that in the chat. So postpartum pain and medications. Typically, if you're had a vaginal birth, we'll start there. It's a lot of Motrin and Tylenol if you need it, and topicals. So that includes like witch hazel, ice packs. We have a numbing spray that we will prescribe to you. If you're having trouble with hemorrhoids, we'll give you certain medications to help with your hemorrhoids as well, if you needed something a little bit additional. And if you had a cesarean, after the first about 24 hours or so, you'll have an IV form basically of like Motrin or ibuprofen, and then they'll switch over to just Tylenol and Motrin works really well. There are other medications if you need it. So if you feel like you're not coping well or you have concerns, talk about it with your nurse and with us when we see you, as we can kind of figure out where your pain is and how can we help you have relief. If you have a vaginal birth or not, we don't encourage you to just lay on your back in your bed. So lay on your side. We'll get up and walk around a little bit when you're able to, because all of that is going to help your healing and your swelling. Newborn sleeping and eating patterns. So those babies, if you've had a baby, you can attest to this. They are a little bit off sometimes at the beginning. So they have this kind of second day where they wake up and they're like, oh my gosh, I want to eat all the time, because that first 24 hours or 36, 48, they spend a lot of time sleeping because they were tired as well. So they're sleeping maybe all over the place. They're basically going to eat, wake up when they're hungry, and then want to go back to sleep. Some babies will sleep longer, and it can be a little bit of a distinction of, are they sleeping because they're tired? Are they sleeping because they're hungry? Because babies are sometimes, when they get really sleepy, it's because they are hungry and they're conserving their energy, so then they don't wake. So ideally, if you're breastfeeding, 10 to 12 feeds in 24 hours. So I tell people, while you're awake and it's daytime, encouraging every couple of hours to get up and try and feed your baby, to try and avoid that crazed hunger in the evening, because the babies are tired and they didn't eat all day and now they're like, oh my gosh, I'm hungry. They call that second night where they're like awake and they're like, oh my gosh, I need to eat now. I just gave birth. I'm not being fed through that umbilical cord. I need to eat. They've recovered from their birth or from their C-section, and they're really like, oh my gosh, I'm hungry now. I'd like to eat. So they might have their days and their nights confused a little bit. So sometimes it can be helpful to just kind of encourage them to eat during the day. But 10 to 12 feeds if they're breastfeeding. And if they're formula feeding, sometimes it's a little bit different depending on how much they're taking in. So we will help you with that postpartum if you are formula feeding. And then postpartum education. There is a ton of education that we will go over. The providers will go over when they see you every morning when we're rounding. The nurses have a whole checklist of stuff to go over. There's like videos that you can watch on your TVs. There's some things even in labor that you can like click on and see, on their TVs and for help. So there'll be a whole lot of education. You'll go home with like a lot of education, things that we don't want you to forget will be on your discharge. It'll be everywhere. So don't get anxious that you might not remember something, or because a lot of that will be repetitive to you and will be on your discharge when you go home, because we want to make sure you don't forget those and you have a resource before you go. Oh, and circumcisions, just as I know, if you choose to have your baby circumcised, they typically do it the day after you give birth. So the doctor. So if you do have a vaginal birth, then you will see a doctor for that region. If you choose to do it, circumcisions, the midwives do not do them in this practice.
For the first 6 weeks, we're going to review that for you after you go home from the hospital. So the first particular 2 weeks can be a little bit, challenging. When couples and families go home, I encourage them to kind of take the team approach, have good open communication and just help each other out, because it can, it is a little difficult. You're going to be breastfeeding or formula feeding your baby very frequently, diaper changing, everybody's still tired and, excitingly overwhelmed from the birth. So it does take time to adjust. What is normal for you? We're going to make sure, we discuss, as Nikki was mentioning, about lots of postpartum education. We want to, we review to make sure that you're not, saturating more than a pad an hour. You're not passing a clot bigger than an egg. You're not having any overwhelming anxiety or depression. So we will review the norms and when to call us in more detail in the hospital. And we do, again, have more definitive guidelines for what's normal for moms postpartums versus the baby can be a little bit more challenging. Of course, you're educated before you leave the hospital when absolutely to call the pediatrician. But every newborn baby is a little bit different. We do follow guidelines as far as how often the baby should be eating, how many poops and pees the baby should be having to ensure that they're well hydrated and nourished. When to call, like, again, extreme fatigue with the baby, not eating. And again, you will meet your pediatrician in the hospital, and they will go over exactly when they want to see the baby back in the office, which usually is within a couple of days after discharge. Signs that there may be a problem, again, with mom would be, you having an overwhelming anxiety or depression that you're not coping with, having some heavy bleeding, clots, severe abdominal pain, of course, a fever. The more evident ones would be like shortness of breath, a severe headache, such things like that, for sure that you will call and more than likely go to the emergency room. Baby blues, very, normal the first couple weeks. Hormonally, we're adjusting. We have lots of, thoughts and emotions, and this period of time is normal. But if it extends past the first 2 weeks, then we might want to talk with you. We have lots of resources. Central Jersey has a family health consortium that has excellent, resources for moms that might struggle with postpartum depression and anxiety. And we always review this with all the moms, and it's very real, and we are here for you. And even sometimes just talking with somebody that's, a professional and an expert at these things can help. So please, that's why we will have our 3-week virtual appointment. When you go home from the hospital, you'll call the office. Again, make that 3-week virtual appointment. We try to encourage you to make it with the midwife that helped you deliver your baby. But of course, with scheduling, it doesn't have to be like that. We look up all your information no matter what. And that's the check-in to make sure, you're not having any issues with your bleeding. You're feeling like you're kind of moving towards the right direction of getting back to, you without baby. And that's why it's very essential to do that check-in. We feel it's very needed. And actually the research shows that we should see moms far before the 6-week period, which will be the other visit that you'll make, that 6-week period, where that's more the physical exam. We make sure we'll look at your perineum. We will, check you head to toe. We'll discuss maybe if you want to do the pelvic wellness center postpartum, of course, contraception, and, just chat to see how you overall are feeling. And that's pretty much it. Again, all this is going to be reviewed in the hospital in sections, before you go home, and everything is typed up on paper. You don't have to feel like this is just a note.
There've already been some questions in the chat box about hospital policies and about COVID. So we put this on here, and every time we do it, it changes a little bit. So what we're going to say right now is what's going on right now at the hospital and what the policies are right now. They do change as all of you are in your 3rd trimester. Some of you literally just step foot into that 28th week, and there are others that are very close to delivery. So and because these things do evolve and change, it looks very different now than it did back at the beginning of COVID. And we've had times where things have kind of been more relaxed, and things sometimes where they get a little bit tightened up. So continue to ask in the office and say, like, has anything changed, especially as you get closer to delivery, to see if anything has changed. But right now, the hospital policies are when you are admitted for labor care. So we know you're an inpatient admission. Everybody who's admitted gets a COVID swab. So as you come to the hospital, anybody coming in for just a triage visit to figure out if your water's broken, to see if you're in labor, they'll stop you on your way in. They'll take a temperature of you and whoever's bringing you in and ask you a couple questions, and they get you up to the labor floor. Once you're up there, if we decide you're definitely there for labor, then you get a COVID swab. If you're a scheduled induction or a scheduled C-section, you would actually get your COVID swab done a couple days before you come in. It is only for the person who is inpatient. So your partner does not get a swab. The hospital allows your partner to come in without a swab, without a COVID test, because you are allowed to have your one support person that doesn't have to show verification of vaccination or COVID status. Anybody else coming to the hospital will have to show that. So if you have a second support person there, which is allowed in the labor room, you can have 2 people who come and support you during labor, in addition to a doula if they come. But anybody other than your main support person, so your significant other, if you're married, your spouse, your whoever you deem as your partner who will get that second band when the baby is born, they don't have to show proof of vaccination or have a negative test. Anybody else will have to show proof of vaccination or a negative test, including a doula, when they come into the hospital. So just your vaccination card, or if you don't have, if you have chosen not to get vaccinated, you need a recent COVID test, negative test within 3 days. So that's hard to predict when you're getting close to time to have your baby. Unless you get a test every 3 days, it's hard to know exactly when you're going to go into labor. Once you're swabbed and we're waiting for your test results to come back, we need the negative test to come back before you are able to use the tub or able to use nitrous oxide. So those 2 of the things we talked about to help manage your labor, the pains of labor. So those 2 things both have to come back negative before you're able to use that. And then you are allowed, so 2 people in labor, and your doula, if you have one. After you deliver and after you're done with your recovery time on the labor side, when you're getting transferred over to postpartum, then they revert to visiting hours. And the visiting hours right now at the hospital, I think are 11 to 8. So that is, that's where the visiting hours are. So if you deliver in the middle of the night, which by the way, a lot of you will, because a lot of babies are born in the middle of the night. When you transfer over to postpartum, your second labor support person will have to go home. And then you can come back when visiting hours begin again, which will be 11 o'clock in the morning. Visitors have to be, again, show proof of vaccination or a negative COVID test and have to be over 18. But you don't have to it doesn't have to be the same person who supported you in labor. That you can rotate 2 people in and out of your postpartum room during visitation hours. So those are kind of the general hospital policies around COVID right now. People ask about family visiting both at the hospital and when they're at home, okay? So that is something that is a really personal decision about whether or not you have family come and support you when the hospital and your home. When we first started during COVID, there was no family support. There was no families coming in and out during the postpartum stay. It was in some ways a little weird because there were only people over on the postpartum side were the person who just gave birth and their significant other support person. There weren't a whole lot of people coming or going. But we found that gave people more time to rest and more time to help establish breastfeeding. So there were some kind of those a little bonus there. But it was hard when they were home because they weren't having people come in and out of their house. They weren't having the food being brought in and that extra support. So there is some balance between having a revolving door where people are coming in and out, where you're not getting rest, you're not able to breastfeed your baby the way you want to. There's that side of it, but you also want to be able to have that support that you need, have people help you and celebrate this new baby that you've brought into your family. So there's kind of a balance there, and you have to decide what kind of rules you're going to set for your family. We would recommend that everybody be around your baby be vaccinated. Also, obviously not sick, not any signs of infection, but vaccinated against COVID and Tdap, and we'll talk about that vaccine in a little bit. We would recommend that you are vaccinated and boosted. We do have people who are asking us about that second booster shot. It has not been recommended yet for people who are pregnant. It's recommended for people at high risk, so people over 50 and with a short list of immunocompromised things. It has not been put forth as the recommendation for pregnant people to get that second booster shot. But if you haven't done the COVID series yet, or if you haven't gotten your first booster shot, we would definitely recommend that. We also recommend it for people who are going to be around the baby. We have had a newborn baby within our practice who, after they went home and family was visiting, the baby contracted COVID and needed supplemental oxygen and some monitoring at home. So it's not even something that doesn't happen, because it does. So we want to make sure that we're protecting ourselves and protecting our families. Can be challenging. There was a question about laboring with a mask on. The hospital policy has not changed. The policy is that when you're in the hospital, and there are hospital employees in the room with you that you're supposed to have your mask on. That I have seen there have been less stringent about enforcing that rule, but if you are asked, to put your mask on. You're asked to wear your mask when someone other than your support people are in the room with you. And that definitely is challenging. Which is one of the reasons we're not in the room as much as we used to be, because we're trying to honor the fact that it's hard to have a mask on when you're laboring, but also, trying to, all of us stay protected. So it definitely is more difficult. So I think that covers this slide. Okay, so I think there was a question about how many people are allowed in the room after delivery is done and the patient is shifted to room after C-section. So when you have a C-section, it's just one support person on the labor side. So during your time before and your C-section, and then your recovery time after. And then when you get transferred to the postpartum side, then the postpartum rules apply. So 2 people and they can rotate in and out. I think that covers that question.
Okay, what to do now? Okay, you've got all this education, you're getting towards the end of pregnancy. So what can you kind of do now to get yourself ready and feel more prepared? Vaccines, we just talked about COVID vaccine, the recommendations. We're getting close to flu time now. So some of you may be getting into that. So there is no, nothing has come out re flu right now. So when that comes out, it is recommended that you get your flu vaccine from this practice and CDC. So that is okay to do. Tdap vaccine, that is recommended after 28 weeks, around 28 to 32 weeks is kind of that sweet spot. And that's to give the baby those passive antibodies against the pertussis or whooping cough vaccine, those antibodies. So it's recommended for the Tdap with every pregnancy. For typical non-pregnant people, it's recommended every 10 years, every 5 years if you need a booster because you stepped on a nail or something like that. But it's recommended every 10 years or with every pregnancy, regardless of when you've last had your Tdap. And again, that's for baby. The vaccine's really not for you. It's for that baby to get those nice, good antibodies. After baby is born, in that first couple of hours, you'll be offered a hepatitis B vaccine for the baby. That is the only vaccine that the baby will be recommended to get after it's born while it's in the hospital. So that will be something that you can look up. It is a standard vaccine that the babies get within that first kind of few hours of life. So they typically do it while they're in the hospital. That's something that you can do at your pediatrician's office or whatever, but it is something that will be offered to you when you're after you give birth. Picking a pediatrician. In the registration booklet that you got, or the booklet that you got at the beginning of your pregnancy, or if you transferred in at that time, whenever you had that first prenatal appointment, you were given, your pregnancy booklet from us. In there is a list of pediatricians. That is not an all-inclusive list. Those are just lists of pediatricians that actually round in Penn Medicine Hospital. If you choose somebody that's not on that list, that is fine. You will just have the on-call pediatrician that's on call for the hospital that day who will see your baby, and then we'll transfer all of your records to wherever you go after baby has been discharged. So they'll ask you who your pediatrician is when you come into labor. We'll make sure we have that set in, and then all of your information will go to that pediatrician after you're discharged. Childbirth education. It is really helpful. This is a quick down and dirty kind of third trimester, but we always encourage you to learn more and to really feel like you're prepared as much as you can be for your birth experience and, your postpartum and caring for babies. So, find education that speaks to you. COVID has made things a little bit trickier. As far as in person and, a little bit more the options that are available, and it's still persisted. So we have this that you can do every month if you would like to. Evidence-based birth has some really great education. The hospital has a lot of basic education as well. On their website, they have a virtual tour. They're not doing in-person tours the last time I knew, but they do have a virtual tour on the hospital, and they do have some kind of childbirth education classes that you can do as well through there. And there is a list. If you would like a list, you can always email Jen. She's got the list. You've got our emails. When Jen emailed you guys, all of our emails were also on that list. So you can email us and ask for that, and we can send you the list of kind of some top ones that we found people really seem to enjoy, and that seemed like a good option. But there is no right or wrong answer on childbirth education, exactly what you want to do. Find what you really want to know more about, and then kind of look for the information on that. Hiring a doula. Jen talked really well about that when we were talking about the Lamaze in hiring a doula. They're kind of the second extension of us, and they're fantastic people. So doulamatch.net can be a really great resource when you're finding a doula. Your friends, if you're pregnant, may have good resources for you. But if you don't know somebody, and get started early, because they can get booked up. So if you're thinking it's something you might want to do, reach out to them. And get and see if you can get connected with them. Packing your hospital bag. We really would provide you, if you were to go into labor while you're grocery shopping and you need to go right to the hospital, we have everything that you would need to take care of yourself and your baby at the hospital. Now, it's helpful to have that bag kind of booked up and ready to go at the end of your pregnancy with things that you would like. Pillows, right? We're always searching for pillows in the hospital. So having a pillow that you may like is helpful. Having snacks, because the hot food down in the cafeteria closes at about 6:30 and it's not open again for like 12 hours. There's vending machines, and we try to keep, snack sandwiches that we can have available if you deliver overnight. But it gets a little bit harder to do. So bringing some good snacks, because your breastfeeding can increase your hunger, and you've birthed, you've just labored for hours and you're just starving, you have something that you enjoy eating after you give birth or while you're laboring. I don't know if we touched on it a lot, but we encourage you to eat and nourish your body even when you're in the hospital. The only reason you cannot eat is if you have an epidural, and then it's just, liquids, clear liquids that you would be recommended after that. Packing, also making the space your own. So when you're packing that bag, you think of what's important to you. If you think that having lights is important to you, or having pictures. I had someone who had brought pictures that were on a string, and they had them all over the room, and it was really beautiful because their other children couldn't be there. So she had just pictures of her babies all over, with some lights, and so we can do like those little candle lights that are battery operated, no active like burning flames, but those little candle lights we can turn the lights down. You've got one wall that's all just windows, so you have a really gorgeous view from outside. If you're on one side, the view is pretty great on both sides, but one's a little bit better than the other. So really just making that your space, and finding things that really make you feel comfortable are really what's important. And then having a couple of changes of clothes, obviously. If you're breastfeeding, if you have any breastfeeding, bras that you enjoy, or tank tops. But other than that, we really supply you with everything that you would need to care for your baby. And then getting your house ready for a newborn. So getting the nursery set up, however that looks for you, whether, your baby's going to be in your room in its own crib, or you want to get your space set up, enjoy it, right? Make it comfortable for you, and have it where you think you might like, and have things you think you might like ready. Make that, your own little space before that little one is here. And then rest. We know this is a really hard time at the end of pregnancy. It can be so hard, and you could be so ready to just give birth and not be uncomfortable in this 90, 95 degree heat. But this is the last time where your little one is literally with you 24/7, and you feel those little kicks, and so try and really enjoy that little peaceful time while that baby's in there kicking against your belly. And getting all those oxytocin, love hormones just flowing to help you prepare for your labor. Let's answer some questions. Can we plug in? Yeah, bring as many electronic devices as you want. Diffusers are fine. It gets a little bit if people have allergies. I haven't really heard that much here at this hospital. At a previous hospital I worked at, we did have like a lot of allergies, nurses and stuff. So it got hesitant, but I haven't heard of, seen too much of that here. Fans, those battery operated fans that like you can clip right onto the hospital bed are fantastic. Because it can get really hot for pregnant people while you're laboring. Tdap vaccine is not too late at 33 weeks. That's just a sweet spot. If you're, past that 32 weeks, it's okay. It's still recommended to get your Tdap whenever you can. We don't offer them in the office at this time. So, at a pharmacy or if your primary care will let you do like a walk-in kind of Tdap, that's fine. Oh, sorry, Jen addressed some of that. Any other questions? This is kind of bulk of it. We've kind of wrapped it up. We're about a little over an hour and a half is our typical time here. So feel free if people want to speak freely because they don't want to type in the chat. And we'll try to answer some of your questions.
There was a question about learning how to give the baby a bath. And the hospital used to have what they called a bath class. They quit doing that, but they do encourage you when it's time for your baby's bath. If you choose to have your baby bathe at the hospital, the person who's helping give the baby a bath will encourage you to come be part of that so you can learn. We don't do it usually for at least 6 hours, sometimes even more like 12 to 24, because we really want that baby to be really good at regulating their own body temperature and blood sugar before we really get them cold by giving them a bath. But they will go over a lot of stuff. And that is also one of the videos I think Miranda talked about that you can watch on the TV. There's lots of videos. I think there's a taking care of baby / giving baby bath kind of video that you can watch.
Mm-hmm. I will add to that there is absolutely no evidence that a bath is necessary. And there's lots of good reasons to delay the bath for, a couple of days or more. As far as things like Jen said with blood sugar control, temperature regulation, and breastfeeding and bonding. There are some hospitals that aren't even doing baths at all now. So just look into the research in that. So you can, that's why we are kind of extending our time of when we give baths here at our hospital. And just look at the research a little bit to decide what's best for you and your baby.
There was a question I seen about the car seat, and I know they do offer car seat checks at the hospital. They make an announcement, but Jen, I'm not real sure. Is that done like regularly every day during the week, or do you know like the exact, if it's done all the time?
Yes, I think you go like the community wellness site to look about car seat checks, but also check your area. Like I know in my area, like the fire department or the police station will do them as well.
Right. And I know they do them at the hospital. I'm just not sure if it's done like every day.
I don't think they do it every day.
Yeah, just certain times.
Yeah.
So it's a hit or miss.
So I know that the nurses do the recall check here though, right?
Mm-hmm.
Right. So they will need your car seat physically here and on the floor, because they will check it against the national recall list to make sure that there's no recalls on your car seat for you. But the actual installation of the car seat, you should have someone check that and teach you how to do it beforehand. And like they said, there's the car seat lady is a great place to look online, as well as the community wellness center, the local fire department, police departments, all do it as well. But it's definitely something that you want to consider doing with your particular car seat in your particular car before you come here to have a baby.
There was a question about registering for the hospital. So that book that you got at the beginning that we've talked about, we give it to you at your very first visit. And a lot of people just put it over to the side, but we keep referencing that. So find that. And if you can't find it, ask for another one, because there's a lot of good information about the hospital. But the back page of that book is your hospital registration form. Now is a great time to do it. So go ahead and get that out, fill it out, and send it to the hospital. The second page on the back of it, there's ways to send it. You can email it, you can fax it, or you can actually put it in snail mail and to get it there. But it tells you the 3 different ways on the back of that form about how to get it to the hospital. It will ask you like who your provider is. People want to know what specific person from our practice to put down. It does not matter. Put Delaware Valley OBGYN, and if you want to put one of our names, one of the doctor's names, they would just put you in as a Del Val patient, because it really is whoever's there when you go in on call is who you're admitted under. But go ahead and register now. It saves a little bit of time and makes your admission to the hospital a little faster. And if you do happen to need induction or a C-section, it makes booking that easier if you're already registered.
Yeah, so you don't have to do, after you send the form in, like that's it. You don't have to do anything else. That answers one of the questions in the chat there. There's a question about a partner wanting to help catch the baby. Absolutely. As far as tips, I guess one of the things when my husband caught ours was I made him YouTube a lot of births. So he was comfortable with that, right? Because we can't see them. So he was like, you know, he wanted to do it, but he wasn't sure. So we watched a lot of births and talked about it. So, you know, it will help you. We might have to, you know, we'll put gloves on it, you know, your partner, and help with hand holding and, you know, things like that will still be present. So we can kind of help guide through that. What other tips do you guys have for him, for that partner?
I definitely think knowing what it looks like is helpful, because sometimes people are surprised. Yeah, and then there's a really good book called The Birth Partner, which is good for anybody, even if they're not wanting to actually catch the baby, but if they're looking. I think there's a question way back at the beginning about what partner duties are, and really your partner duties are whatever they want them to be. We will encourage you to be as involved as possible in the process. So I think one of the hard things for partners is this is your person who you're now seeing laboring and some, you know, some discomfort. And even if you as the birthing person recognize this pain as pain with a purpose, and you understand that it is normal and natural, when someone loves you so deeply and so dearly and they're watching you struggle, sometimes they look to us to help you fix it. And we understand that it doesn't need fixing, right? This is a normal process, but for them, they don't want to see you in pain. So for them to read some stuff to get some tools, so the birth partner is good, and any other like extensive childbirth classes for them to kind of practice with you the things that they might find helpful to, you know, support you and know that this is normal and natural.
And I think too that the Community Wellness Center does have a daddy boot camp, which of course is for any birthing partner, not just stereotyped daddies. So you could definitely check that out as well. And then someone was asking about bringing a tripod in the room for pictures. They do have professional photographers here to take portraits of your baby after birth. You can definitely bring a tripod as long as it folds up and, you know, goes away in an emergency. It's not in the way. However, the hospital does not allow you to take pictures of the actual birthing process, unfortunately. So, you know, just keep that in mind if that helps you to make a decision on whether or not to bring a tripod. The hospital does have access to formula and will have that available for you, you know, in case you have breastfeeding issues.
So I'm trying to figure out this question about 7 and 8 months is trickiest, and we need to do complete rest. Trying to understand. So I'll talk a little bit, and if that doesn't cover what you're asking, let me know. I don't know what's the trickiest. I know that the last month of both of my pregnancies felt like an eternity, you know, so I felt like every day felt longer than the day before. But there is almost no time in pregnancy where we would recommend complete rest. It's actually the opposite of what we generally recommend. If you're having a normal, healthy pregnancy and we're not worried about like placenta previa, where your placenta is blocking the, you know, down at the cervix, or, you know, you've had a lot of, you know, preterm dilation and contractions, we recommend movement and activity and, you know, continuing to exercise. I'm not saying if you've never been somebody who exercised that now is the time to start training for a marathon, but the more we move, the better, even in our 7th, 8th, and 9th month of pregnancy, up until and including when we are laboring. Movement is actually really good for us and really good for our babies. So we don't recommend complete rest at any point, not even what we can call pelvic rest, which really means no sex or anything in the vagina. If you've not had if you've had an uncomplicated pregnancy, then you're able to have sex, you know, with your partner up until your water breaks, right? So you can continue to do that. What we do recommend is you trying to find ways to intermix your rest with activity. So if you have a busy day, so you do activity and then you take a rest and put your feet up. You know, that's why the last month of pregnancy, a lot of people are not working, so they can, you know, can do some stuff and then also have periods of taking naps because sleep gets hard at nighttime. So trying to find a way to get some rest and, you know, get some sleep in there, intermixed with activity and exercise, working on, you know, keeping your body moving, because labor is a strenuous event. So if you rest for the last 3 months of your pregnancy, you're going to have a hard time figuring out how to do the strenuous work of labor. think there was a question about recovery from a normal / vaginal delivery versus a C-section. In general, as far as like physically being able and recovery, your C-section, you're not usually told not to drive in the very beginning, whereas, that's not necessarily the case for a vaginal delivery. Depending on your, the significance of how much you tore and how many stitches you got from a vaginal delivery, you may have some more discomfort than someone who doesn't have a tear. But the first couple weeks after either kind of delivery, you're going to need a lot more rest, a lot more help around the house and doing things. But in general, you'll certainly start increasing your activity. We consider you like recovered and able to resume like normal activities at 6 weeks for a vaginal birth and 8 weeks for a C-section. So you're going to need more help around the house and you're going to have more restrictions as far as lifting and movement with a C-section, but with a vaginal delivery. But in general, it takes a long time to grow a baby, and it takes a long time to for your body to kind of completely get back to normal. It's a gradual process from after you deliver until you kind of feel more like yourself. It's not like, at one point you all of a sudden feel, completely recovered. All right, so I think that we've covered all. Oh, another question pops up. Okay, no, person said thanks. I think we've covered most of the questions. You guys were super active in the chat box, which is great. We'd like to answer as many questions as we can. We do this session once a month. You're welcome to come to another one. Occasionally we'll change the slides here and there, but the conversation is also driven by the questions that are asked. So people find it helpful sometimes to come to more than one. Tomorrow, I will send out an email that has some links to it for other childbirth classes, for the tour for the hospital, some information about perineal massage, which we didn't talk too much about here, but that can help reduce your risk of tearing. And then a link to this recording once it gets, completely, it has to do its little thing on the computer and be set, but then I can include a link to that. We'll also include a survey. We always want to know what we can do to improve this, because we're always trying to be as helpful as we can in a very short amount of time, because I know it's hard to sit and listen for 2 hours. So I hope you guys enjoyed it. If you have, we'd love to see you in the office. So some of you, I think I have an appointment with a couple of you tomorrow, but make an appointment with one of us, kind of rotate through all of us so you see us, so you'll know who's going to be there with you when you deliver. All right, you guys have a good night.
Thank you so much. Good night.